So today we understand how to get better results in the clinic using OccluSense. But before to go to the clinical situations, it's very important to understand how this device works. It's an electronic sensor of pressure that registers the occlusal contacts in theirs and their intensities. This is very, very important. So we have a hardware with these pins that connected with this sensor. The core of the device is the sensor. We will explore more. And the information that are captured here are transferred through these pins to this app that is used in iPad. So let's understand what makes this sensor so special. The sensor, it's really, really sensitive, okay? It's a sensor with 60 microns of thin. It's very thin, very, very thin. Remember that we use normally 100 microns papers to check the occlusion. So it's really thin, flexible. This is very important to modeling the occlusal anatomy and then record the contacts. It's coated with a transferable color. This is really good because we can relate the information that we get with the app and with the contacts in the mouth. This is really, really useful. But here it's the main information. We have more than 1,000 points of sensibility to pressure. This makes this sensor very, very sensible to pressure. And each of one of these points that are able to register the pressure can register this pressure with 256 different intensities. So what it means? It means that we received a lot information about occlusion dynamic. This is really important to understand, to know how to filter so many informations to find what we are looking for. So how it happens? We have two sheets. Within these 60 microns, we have two sheets. So it's a really technical sensor, and we have two sheets with electrodes between these sheets. And when we have no pressure here, we have this condition. But when we have a point of pressure, what happens is that both sheets will be compressed and touch, and then we will have electricity passing over this connection. So how much this connection is interrupted is the intensity of the contact. So if I have a low pressure, I have some contacts happening, but with high intensity of electrodes, electric pathway. But with this is recognized by the system that is low pressure. When I interrupt this current, the software interprets that this is a high intensity of contact. And we will read this in the graphics, but it's very important to understand. But how is divided this zone? It's like zones of pressure. We have these zones, and the sensor is divided in the middle, and then I have some data that are quarters data here. Some data are in the middle. These are the middle. and we have the individual data. The point is that the system calculates these intensities and this data from 100%, and then the system calculates the percentage of each of this area. So for this specific way to calculate the data, that I cannot compare one patient with another patient, because we don't have a reference point to make this comparison. Okay, we can compare always patient to the same patient in different moments, but I cannot compare this patient with another patient because I don't have a reference. It's always, the data are always distributed from 100% from that patient. Okay, and what we have here more, we have the colors. What means the colors? The colors means that the size of this contact. If I have a flat surface having contact with another flat surface, I have a large contact. This is represented here by green color, the green columns. If I have punctual contact with punctual contact, I will have, the system will register the size of the surface as red. So what we are looking for in dentistry, we are looking for red columns, okay? Because more efficient, it's an occlusal contact when we have punctual with punctual contacts, not large surfaces. And the height of the column is the intensity of this contact. It's how intense is that pressure in the sensor, and the system calculates this intensity also related to the 100% of the contacts. So it's a proportional distribution between the teeth, not between situations or between patients, but between all the contacts. The system calculates the difference and the distribution of these intensities. Okay?
Yeah, okay.
So after understand how the device works, let's understand the importance of occlusal contacts and how we normally interpret this information and how the system will give us this information. The distribution of the contacts, first of all, is that occlusal contacts just happen because I have muscle activity, okay? Maxilla, upper jaw and lower jaw have no contact if I don't have muscle activity. All the function of the system happen because we have muscle activity. And this muscle activity leads to the result of these contacts. And the distribution of these contacts will relate it to the system stability. So if I have a great difference between joint position and teeth position, the joint position is stable and teeth position is stable, we will have more muscle activity to achieve both position. And when I get the teeth position, if I have a poor distribution contact, a poor teeth relationship, I will have a poor stability of the system. So it's very important to understand because normally the system will show us this instability of the system. When I don't have good contacts in good places, I don't have a stability of this position, and the system will register this movement, and it will be confused for us to understand what is happening. For this reason, it's very important to have these informations in mind to interpret the data. And also, this function works also to muscle efficient. If I have a slow down muscle activity, a very soft activity of these muscles, the system will register one information. But if I have a hyperactivity muscle because of difference between joint position and teeth position and parafunctional dysfunction, if I have this muscle very active, I will get this activity also with the system, with the device. This is really, really important, and I will show you clinical situations where we can see this relationship between muscle activity and the registration of the data. So the quality of the muscle activity will determine if we have a balance or an unbalanced system. This is really clear when we have a patient with a stable system or a very unstable system. This will reflect in the muscle activity. So this balance or unbalance of the system will result also in adaptability able. So this adaptability, it's very individual, and we cannot put everyone in different boxes and say, if we have this situation, this patient will develop on this way. It's impossible. We need to understand that muscle activity can result in balanced or unbalanced system. It shows us if the system is in each condition the system is, and this balance or unbalancing depends on the adaptability of this individual, this person. Okay, this is really, really important. The muscle function, it's really important because it's the OccluSense is the only device that we can see the muscle activity and occlusal contacts at the same register, the same data, and the same information. Normally, when we make electromyography, we see just the muscle activity, and when we check the occlusal contacts with papers, we see only the contact is the occlusal reference. But with OccluSense, we can see both, and it's really, really interesting. So to understand in each condition this system is, it's really important to make a very, very complete and good anamnesis and well-directed anamnesis. Why? Why anamnesis is very important? Because it's part of a puzzle where we will check the symptoms and the signs, the symptoms of this system that indicate some unbalanced situation. And the clinical evaluation will check the signals of this unbalance. So if I don't know what I'm looking for, I will not be able to recognize what I will find. This is really, really important because just use OccluSense and wait and expect that this information will give all the condition of this patient. It's a great error. So I need to understand the claims and the symptoms of these patients, related these symptoms with the signals of the imbalance. Which are these signals? Facets, cracks, sensitivity, cervical non-carious lesion, gingival retraction, movement of teeth. All these signals are a reflection of an unstable system. Something is happening that it's overloading a part of the system, and the teeth are showing that we have an imbalance. Which signals more we can relate it with an unbalanced system. The clicks, the joint pain, the headaches, all these signals and symptoms are directly driving our attention for that this system is not in a good balance. So we need to drive our attention to ask to OccluSense, where is this point of unbalance? And then we can interpret the data. Remember that we will receive a lot of data because the sensitivity of the sensor. So we need to understand what we are looking for. Let's understand how we were trained to check the occlusal contacts. This is really important and makes a great difference in the clinical. So we were trained, for example, to understand the occlusal contact with papers. If I use a 200 microns paper, I will have this kind of contact. A large surface, normally with a darker color around the contact and a clear color in the center. What means this? It means that this paper, it has a glue and it has a color. When I use a 200 micron paper, I'm transferring the glue here and the color at the same time. But with this contact in a more thick paper, this color will put to the periphery of this contact, of this color that were transferred to the teeth, but with glue. This is really interesting, the technology that Bausch papers used. The same contacts with a 100 micron paper will give you a different contact. Look at the modeling of the modeling able of the occlusal anatomy will give us smaller contacts with the same pattern. Glue with color, and this color it's put to the periphery of this this mark. And when I use a very, very thin paper, like 8 or 12 microns, that don't use glue, this is important, this is different. 100 and 200 microns papers, they have glue, the others don't. But the thin paper will modeling this occlusal anatomy very, very well. And we will refine this registration of the contacts that are very punctual. Pay attention that we have the same occlusion, the same contacts that are registered in different color views. So what do we do normally in the clinic? We use normally 100 to transfer the color, and after that we use 8 or 12 microns paper without colors in a different color to check this distribution. This is the area, the punctual area, but normally but sometimes I can have a more large surface here. And why do I normally combine both papers? Because if I have a very glatt or humid surface, since 8, 12 micros papers don't have glue, sometimes I can not transfer the color, the pigment, to the teeth. So we use this trick and this technology in our favor. We use, but we consider always the smaller contacts, because here it's not the real contacts. Because of the thickness of the paper, we have more surface marked, but the real contact, it's that. We will understand this in the occlusogram by scanners. This is really, this works at the same way to understand the contact, but and with some difference that we will see there forward. So what happened here? Normally, when we use papers, here I have combined, and I have the glue that is blue, and the red color representing the real contacts. What do I have here? I have large surface of contacts. And this is not good. Since I have a good occlusal anatomy, I don't have good contacts in this system. And what is the main information that I have here? When I make this kind of registration of occlusal contacts, what I'm seeing here, I'm seeing the summarize of the whole movement since the beginning, since the first teeth contact until the end, all contacts happen together. So I don't know which contact happened first. I don't know the intensity of this contact. If I ask you which contact is more intense, this or this, maybe you will give me an answer. I will give you another answer, and a third person will give another answer. Why? Because it's very subjective, very, very subjective. Normally, we interpret this data. We were trained to do that, to make the adjustments, but it's really pretty individual and subjective. So keep this information in mind. Here, I have a representation of the whole movement of occlusal contacts. From the beginning until the end, I have the sum of all the contacts that happen during this movement. And I see all together. And how it happens with scanners. When I go to digital tools, I have many different tools. I have the occlusogram from the scanners from different systems. I have different softwares as Mesh Mixer, Exocad, many different softwares. And we need to understand how these systems, this digital system, calculates and interpret the data. Different from in patient and real patient with papers. The systems, they calculate the distance between the meshes. So if I'm working with an intraoral scanner, I have an upper mesh, upper jaw mesh, lower jaw mesh, and then I will register the occlusion. First point, this relationship, because upper mesh and lower mesh, it's a photograph. It's not a summarize of the whole movement. It's a moment from that contact. Okay, this is the first point. It's And when I get the relationship, the occlusal contacts by intraoral scanners, I'm getting one side, and then I need to remove the intraoral scan and register the opposite side occlusion. We will see that the muscle activity have some differences to keep this occlusion. Remember that the contacts, the occlusal contacts, they happen just because we have muscle activities. So here I have one picture and another picture from different moments and different muscle activity in different moments. So the softwares calculates the medium of these contacts, okay? Oh, it's precise. It's precise for prostheses, for the general situations. It's precise, okay? But for refined information, for refined studies from this occlusion, this is not the better way to check the occlusal contacts. And the second point for scanners occlusion, here we work with distances. So we have the red points, the real contacts. What are real in contact? The other colors are distance. And here it's a very important information. Look that all occlusograms in intraoral scanner systems, we have these scales. All of the system, we have these scales. What means these scales? The distance that are related with the distance of the colors that are related with the distance of the meshes. Okay, so when we look for iTero occlusogram, we have a big problem. Why? Because the red ones, they represent the red contacts. They represent contacts that happens from 0, the real contact, until 0.2 microns. How much is this? 200 microns. So for occlusion analysis, 200 microns, it's the maximum of occlusion that we expected. Normally, we use 8, 12 microns to refine this information. And here, I'm not able to do that. I put everything in the same pocket and interpret as contact, but it's not real. Normally, we have one contact happening in 12 microns, and the contact that will happen when I reach 200 microns, it's at the end of the occlusion and with a lot of force of the system, with the maximum muscle contraction. And this is, it makes a little bit confused when I use this to refine the occlusal contacts, okay? And when I go to system for example, to mesh mixer, I have to understand that the contacts are represented by a cross of the meshes. Here I can see very well. I have one mesh going through another mesh. And normally I hear from colleagues from technical, they say, oh, the registration is wrong because the meshes are crossing over them. And this is what happened, because when I have a mesh here and another mesh here, I have a static file. How is in the mouth? I have muscle and I have gonphoses. I have movement of the teeth during this occlusion. So this crossing of the meshes, it's how much gonphoses I had related with the muscle force. it's complex, but it's very important to interpret right the data. And we will understand that we will see all this information with OccluSense. So, and how can we interpret the data relating all these digital tools? I must have in mind all these differences, because if I think in just in one way and want to compare all this, it's impossible because they are registering different things. When I'm looking directly to the mouth with papers, I have one result. When I'm registering from scanners, I'm registering just one moment with a picture. And when I'm using OccluSense, I'm registering all the movement in different times. So I need to understand and stay at the same time, at the same point to compare them. So here I have OccluSense that I can relate it. I can find the same picture with both devices. Yes, I can find here that I have 2 points of occlusion here, and I have here. I have another in a lower intensity. I have this distance happening in another intensity since I have muscle contraction, but I needed to look for this time to relate to this, because we will see that these contacts are not kept stable during all the movement. This contact normally, mainly when I have an unstable contact distribution or contact unstable occlusion, I have instability of this occlusion. What happens is that the OccluSense will register all this time, all these movements, and scanners will register that picture from that moment. So I can relate it. Yes, I can make this correspondence, and mainly when I can adjust the occlusogram. Some scanners give us these options to adjust to 100 or 200 microns and have just these points and related with OccluSense. So how interpret the habitual positions? I want to show you now with these devices how we can interpret these different tools. For example, here I have an occlusal contact in maximal intercuspal position, and I can find these contacts. I can represent these contacts here with OccluSense. Okay? If I turn around and if I put here, I can relate these contacts with OccluSense and occlusogram from scan. But what really happens? Let's see. This patient starts to close here, and then she moves to the other side, and then the contacts will happening, and then I can reach the same contact. But look here, I need time to get this, and this contact, it's not that all the time. This is very, very interesting because we can see the dynamic of occlusion, and we can see how stable is this contact, are these contacts, and I can see how much this system needs of muscle activity to reach the maximal intercuspal position, because here this is the maximal intercuspal position, but this patient doesn't keep this maximum occlusion. all the time. The muscles are not able to keep this maximal contraction all the time. This is physiology of muscles. So since I have a good distribution, this distribution, it's not stable, okay? And here we can see how OccluSense registered this muscle activity. This is the same patient, okay, with different commands. Here I ask, please just close. And here, close with maximum force. Let's see what happened. This is just close. I have this distribution. And now close with maximum force. If I didn't do the information, you will tell me that are completely different patients, are not the same patients, because the graphics are completely different. And how can I use these strategies when I'm using OccluSense? For example, when I'm working with here, I have the maximum gone forces and maximum muscle force. So if I'm working with implants where I don't have gone forces, to make the adjustment, I need this command, make the maximum force. Why? Because during the mastigation, I will have this situation. So the adjustment need to be made with the maximum force, considering the maximum gone forces not to get damage on the system during the function. So if I just tell to the patient, just close, 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 and adjust this implant, this crown over implant, probably I will not see this situation. So the OccluSense allows us to understand the dynamic of occlusion. This is really, really rich to apply this concept in the clinic and use OccluSense to check this distribution. This is very, very helpful when I'm adjusting crowns over implant, to use OccluSense to check this maximum intensity and adjust to the same intensity for all teeth in maximum intercuspal. This is the maximum intercuspal, not this. So, and another point is that the system is not able to keep this maximum intercuspal position for a long time. This is physiology of the muscle fiber. They have the maximum ATP use and maximum contraction, and then when this ATP is over, this fiber is relaxed, not to the relaxed position, but in the middle of this contraction. So for this maximum activity, I have around 4 seconds. Let's see what happened. Look that. Close. Oh, now close again with more force, but look that the contacts are not kept for a long time. So this is very common and we see all the time. And we can also make diagnosis how stable is the system, because if I have a good distribution, it's easier to the system reach these contacts. And I will have a repetition when I ask to the patient, open and close, open and close. I will have the same graphics happening all the time. But if I have an unstable contacts distribution, the system will have to make more force all the time to slide to reach all the contacts. This is very clear when we use, and I learned these functions using OccluSense along the time. So here is what I was telling you about stability of the system. When I ask to the patient, open and close, open and close, open and close with maximum force, I can understand how stable is the system. Look that the graphics repeat all the time. Look that. Just with different intensities, but the contacts are always at the same place. And here, this is an unstable patient. The graphics, they don't repeat themselves. I receive one graphic. I ask to close again, and I receive another graphic. This is an unstable occlusion. This helps us a lot at the diagnosis phase to understand how this system is working. And the last concept that we need to check and we see, it's the gonphoses. If I have teeth with teeth, I will have these movements. All the teeth will have some movement with the ligament, the periodontal ligament. But if I have an implant, I will not have the movement from this implant, just from the teeth. So it's very important to consider when we are adjusting crowns or restorations, when we are analyze the system as a whole system. I need to understand, what do I have? Do I have just teeth? I have teeth occluding with an implant. I have implant with implant. I have a periodontal disease that will give more movement for these teeth. What do I have to analyze this occlusion? For example, which kind of material do I have in a natural teeth? For example, if I have resin, I have a more elasticity to this material, more dissipation of the force. If I have a zircon, I will concentrate this force here because it's very hard restoration that will concentrate the force in the root and in the ligament. So we have some details that we cannot put all at the same boxes. Definitively, we cannot put all these informations in the same box and say, no, everyone works at the same way, every teeth and every material works in the same way. No, we need to understand what we are observing, what we are analyzing to understand the results that we will get with OccluSense. So the point where it's very the differentiation of OccluSense, it's the dynamic occlusion registration. This is gold at the clinic. Why? Because I can see the first contact and how this lower jaw is light to reach the other contacts, and how these contacts will happen during this movement. It happens very, very fast. But imagine that the whole day this contact happening, for example, and how can I relate this information with clinical signals and signs? For example, I receive a patient that has sensitivity in a specific tooth. So I can check with OccluSense how much contact, how long is the contact over this tooth, and how the intensity is over this tooth and correlated with this sensitivity. And how I will adjust this, I will decide based on the occlusion analysis to understand if I have to say I need to reanatomize this occlusion, this anatomy. So this is very helpful to correlate. Normally, we can see tooths that crack, that they receive more force, more intensity of the force during the movement. So here it's a case to illustrate that. I have a good relationship, class 1 of molar, class 1 of canines, a very good distribution. Here also class 1, also class 1, no facets here, good inclination of incisors. So it's a very, very good occlusion, yes? This is how we analyze normally this occlusion. But when I analyze, she has a good anatomy, occlusal anatomy, okay? But she has a claim about these premolars, a sensitivity of these premolars. And her first contact in central position is here. For this reason, I have this mark here. And when I check the distribution of contacts, since I have a good anatomy, I don't have a good kind of contacts. I have very large contacts. And look that the teeth that presents sensitivity, I have the first contact over it, but I have also a very large contact. And here I have only contacts, very, very large contacts. We will see this with OccluSense, how it appears with OccluSense. But look that it's not functional this kind of contacts. We need to have more punctual contacts between to slide more ease. Here she needs to make a lot of force to make the function. And the same situation here with a lot of contacts in the anterior teeth. And look here, the contacts. I have a lot of large surfaces with this occlusion. Look at that. I have good contacts in punctual, yes, but I have a lot of. So how can we adjust this occlusion? Now, here with this graphic, I will not give the answer. We need to have the puzzle, the total puzzle to make some decision. This is an occlusal functional analysis. But here I have a piece of this puzzle that is I don't have a good contact, a good kind of contacts to a good function. Yes, it's very large. I'm looking for more punctual contacts. So we need to understand. And here I can adjust and filter that data. And look that. Remember that I told you at the beginning that the sensor will model the anatomy, the occlusal anatomy. So here as I have large contacts, I have the sensor making contacts because of the occlusal anatomy. When I filter this information, remember that I can filter the intensities of 256 different intensities of that contact. I can clean the data and see what is happening, really happening. This is more more look like that what we saw with the scanner, the occlusogram of the scanner. Look that. Very large contacts and the punctual contacts happening just in the front teeth. Okay, so I can use the filter to clean the information because the sensor will give you a lot of information because of the sensitivity of the electrodes, and we need to clean. Okay. From this to that. And here are the movements. The lateral movements. Look that it's to the right side, but I have non-balanced contacts too. This is very, very bad. And to the other side, now to the left side. Sorry, it's the opposite. Here it's to the right side, the other to the, let's go back. Here it's the maximum intercuspal position, and then to the left side, look that the movement, it's happening only here with interference here, okay? Look that this occlusion to the left side is made in the molars. Now the maximum intercuspal position, and to the right side, this is a little better, but I have also an overload in that molar. And then maximum intercuspal position again and protrusion. So what happened here? If I show you this and I don't tell you what it represents, you are unable to understand what's happening. So here I go back to that phrase that I told you at the beginning. If you don't know what you are looking for, you are not able to understand what you will find. So to use OccluSense, you need to have a question. What I'm looking for? How is this occlusion, the right movement working? And then I register this movement and go to the right side, and then I can check the contact. If I don't have this question, everything that I see, I don't know what is. And in the system, it's very important to write what is the movement, because if I don't make that at that time, after I will not remember. So this is very, very important and necessary to do the question, what I'm looking for, to interpret the data, to use the filters, and write what means that registration, because in a second moment I will not be able to remember and to know what is. And create a protocol to register all your cases in your clinic. If you have a step-by-step that you use for all patients, it's easier to train your team and to make a protocol. And then you use in different ways in some specific situation, and you write down. But if you don't have this protocol, you will get loose with some many informations that you receive from the system. This is really important. So until now, we just talk about the device, and now I will show you some clinical applications, how we can use all these informations with this device in clinical situations. When to use? I always use OccluSense for oral rehabilitation. it helps me a lot to make decisions when I work with many teeth. This is very, very useful in the clinic. So, and I use in the provisional phase and definitive phase. So here I have a clinical case. This patient arrived to me with a lot of teeth sensitivity because of erosive related with reflux. Aesthetic a lot damage, but with crossbite, periodontal disease, a good position of these anterior teeth. So we decided to make the provisionals, the provisional phase to improve the sensitivity and gives she a better aesthetic to make the orthodontic movements, and then go to the definitive crown. But I need, when I planned the provisional phase, I had no perfect occlusion distribution, because we will have orthodontic treatment, and it was not possible. But I needed at least a balance between the sides, and it was which I did here. I have here the provisionals, red instead, and the adjustment of this provisional, getting a balance between the sides. Okay, no contacts in the anterior teeth because we will have movement here, but vertical dimensions recovered with no sensitivity. This patient could not eat or drink because of this sensitivity. And now she had a static condition to contribute with the orthodontic treatment, and then we get the end, a good position to reach the final the final definitive crowns. Here are the definitive treatment, definitive crowns with here I have ceramics and resins, milling for both. I mixed the materials, and we have a very, very good occlusion, anatomy, distribution. And here it's how we finished the case with a very, very good distribution. But if you will look here, I have a contact more intensive in this central incisor. And if you remember, I had at the initial phase of periodontal disease here, and we have a defect also here, and these teeth doesn't accept this contact. So I adjusted this contact, because with papers I didn't see this. It was not registered here with normal papers, but with OccluSense I could identify this contact and his intensity, and could adjust. And here it's how we started. Here is how we finished. And here it's 1 year control of this case. This case has many years already, and it's very stable. Look at it's all the contacts very balanced 1 year after. So when to use OccluSense occlusal splints? Wow, this is very nice. Why? Because I can show to the patient that how I finish the treatment, the splint day 1, and we can make controls over the time, and I have objective considerations to explain why this patient should or not to use the occlusal splint. I can show to the patient if I have this adjustment of these splints, and I can explain to this patient that if she or he doesn't use the splint, this adjustment will happen with the teeth. So it's very useful to make this control over the time and to show the patients the importance of the occlusal splints. And to the adjustment, it's also very, very helpful. For example, here I have a splint. All my splints are planted in RP position, in centrical position. And here is the day one of the distribution and how I finished at day one the adjustment. Why didn't I remove these small contacts? Because I had a very, very hyper muscle activity. And I know by my experience that when the patient in this case, used a splint for 2 or 3 days, this contact will change completely without adjustment. So I'm not very, very precise in this for this initial adjustment because I know that many of these contacts are happening because of muscle activity. So this is here, this patient returned in 30 days, not in 3, but I can do this readjustment in 3 or 4 days. So this is the same case 30 days after. So look that I have the same contacts, the main contacts are in the work cuspids, but look that I don't have the small contacts that I had. This is muscle activity. And then I make the adjustment, the final adjustment to reach this kind of distribution. And then I have the day one, and then I can control over the time this splint. And I think that it's not with me that happens, but sometimes I cannot convince the patient that she or he must use oral splint. Why? No, I'm good. I don't have pain. I don't have headaches. I'm good. And when I show them how this splint is important, I can convince better my patient to contribute with the treatment. And here it's how the splint comes to me 30 days after with these small contacts. Here it's a lower splint. Normally it's my choice. I know that it's not the most common, but I like so much the lower splints. It's easy to speak. It's easier to close the lips. It's easy to adapt. And then I use lower splints. And here it's what we register. And here are the contacts after the adjustment. Now I have been using only printed splits. And then this adjustment is easier because what I design with the software normally is what I get in the mouth. Normally I have much less adjustment, and it became a little bit easier my job in the clinic, but I still controlling the contacts over the time. And I have with my patients a specific demand that it's occlusal adjustment post orthodontic treatment. Here in Brazil, we make a lot of orthodontic treatments, and what we see it's with aligners and adult patients, normally facets of where normally anatomies, not good anatomies after old restorations. So we finished the orthodontic treatment, but we need to reanatomize most of these teeth to reach a good occlusion distribution and stability. And this is a scenario that I use a lot, OccluSense, to help me to make some decisions, because different from oral rehabilitation, normally these patients, we just make composite restoration with composite, not with prosthesis for full mouth rehabilitation. And I need to make some decisions for small adds of composite. It's a very hard work and very refined work to establish this occlusion. So this patient, we have some different difficult situations. I have an ankylosis here and here from some teeth, some ankylosed teeth, a trauma here with this central incisor, with a great destruction by palatine. I had to negotiate the aesthetic with the patient for this tooth, because the structure was already very damaged. And let's see how we started and how we finished this case. Look here that I didn't have good function, good position of the canines for anterior disocclusion, for anterior contacts. Here also not. A guide here difficult because we cannot move these teeth. So we started in a bad relationship of the molars. So let's understand what we could to do for this patient, because the movements are very limited. And here it's how we started. It's a premolar. And here is how we finished the orthodontic treatment. If we see, we have very poor contact distribution. And then we started the reanatomization and adds in strategic adds to get a better distribution of contacts and stabilization of the system. So here it's the initial of OccluSense distribution at the end of orthodontic treatment. Look that, it's very poor. Maximum intercuspal position, it's that. And here, after some adds, some restoration, some strategic restoration, reanatomizations to get better contact distribution. This is not the final. We have a balance, but we got better at the end. And the preparation for facets, here an overlay for these ankylosed teeth. A better relationship between canines to get guidance, anterior guidance. And here it's in the middle of the treatment with some reanatomizations. Look that it's lacking the contact here, the guidance. And here it's the final of the case with the facet, with all the restoration. Look the relationship, even we have a not very perfect relationship here, but it's better than the beginning. Here also, and here it's the distribution of the contacts. Look here that I can adjust, this is trios. I can adjust the scale for 100 microns and understand how they happen. The literature brings that we normally have between 100 and 200 microns of movement in gum fosses, 100 microns for each tooth that are in contact, but I have to have in mind if I have implants, crowns, zirconia, periodontal disease, this will change this movement. But normally I adjust the occlusogram for the maximum of 200 microns. Look here, this is 200 microns. This is the maximum force that this patient normally will get the contacts, and here are 100 with no force to check the distribution of this. And the blue contacts are the contacts that are always happening, but the others happening just when we have force. And here it's the final distribution for that case with very good balance, reached at the fine, at the end, with canines, with a good distribution. And this is the same. Are the movements. Maximum intercuspal position, the right side. Now to the left side. Now back, left side. Now back, maximum intercuspal position and protrusion with no interference in posterior teeth during the movements. This is very, very important. No interferent contacts. And here it's how we started, how we finished, the difficult with these anterior ankylosed teeth. These teeth were structured, very damaged, and we negotiated how I prepared this tooth to lanes. Then we negotiated a little bit of the static, not to destroy it so much more the structure, and this is the final result. So this is all. Thank you so much for your attention. And now if you have some questions, I'm open for that.
Hi, Juliana.
Hi, Inácio.
One question. For complete dentures, do you use the OccluSense?
For the complete?
Dentures?
Dentures, I have a problem. I don't have patients that use dentures. This seems fun, but it's real. I have patients with 90, 89 years old, and they don't have total prosthesis. I never used Inácio because I don't have patients using prosthesis, but I think that maybe it's a little bit different because you are the first person that asked me this around the last 8 years that I'm using OccluSense. But thinking here, I think that we have some challenge to use this because of the movement with the mucosa. I never tested. It's a good question. I never test how to use this with total prosthesis patients. I don't know. I don't know how to use these and which will be the observations. But the first thing that comes to my mind is the movement of the prosthesis over the mucosa.
Yeah, thanks.
Yeah, it's a
I'm
challenge.
from
It's a
Chile.
challenge.
Yeah,
It's
I'm from
really a
Chile.
challenge.
Third world question. A lot of denture here in Chile, so we use a lot of 200 microns papers to check the occlusion. I was thinking that OccluSense can maybe get some accurate data for the bilateral occlusion from dentures.
What I would do, okay? Now we will think together. What I would do, I would not use 200 microns papers. I started to use using 8 or 12 microns papers. This is the first point. Since the prosthesis is not by ceramic, it's normally by resins, the teeth, they capture very well the colors of these papers. Okay, we don't need the glue of the papers, the Dickers papers to get the colors, to register the contacts. So I would use thinner papers. Then you can clean better the information that you are registering. The second point, I would start with papers, and after when I see that, okay, for me with papers here would be good, then I would use OccluSense with this. Why? Just to check the intensity, the distribution of intensity, not the distribution of contacts. Okay, because then when I have good contact distribution, then I can compensate the movement of total the denture better, and then get more refined informations with OccluSense. If you started with OccluSense, this unstable distribution, we will move the denture, and maybe the results with OccluSense will be distorted. Then I used in this way with this protocol, not 200 microns, 12 or 8. Bausch has a very, very good 8 microns paper. I love this paper more than 12. It's one color, both sides. It's perfect. It's really, really good. Try it. Maybe it will help you. And a dry surface, and then you use for 8 microns, and then adjust. Let the contacts in work, cuspides, and the good distribution, and then use the OccluSense to balance the intensities of these contacts.
Thanks. I want to try it.
Okay, I do this protocol for rehabilitations. I don't use OccluSense from the beginning. I use papers first, and then when I say, okay, it would be good with paper, then I go to OccluSense to refine the intensities. It's easier. Magda, some question?
No, thank you. I don't have any questions.
Very good. Ignacio, more questions?
Yeah, Juliana, one more question. For implants, can you repeat that part? When there's some unitary implants, how do you use OccluSense in a better way?
Yes. I have to remember that for implants, I don't have gonphoses. Yes, right? When I'm adjusting implants, I have to understand that the maximum force for this implant we will receive during the mastigation, the mastigatory movement. And if I adjust the crowns over implants, only asking for the patients, touch, 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 close, 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 close. You maybe, depends on the patient, the profile of the muscle activity of this patient. Maybe you will not adjust with the maximum intercuspation. Remember that I showed you, if I just ask to the patient, close, open, close, open, close, I have a pattern of graphics. But when I ask for the same patient, please close with force, and it put maximum force, the graphics, the distribution, it's completely different. For implants, you need to ask for maximum force. Then you can understand. Normally, what will happen? Normally, when this patient close in a normal way, this implant will not touch. We will touch with 100 microns paper, but when you use 8 microns paper, it will not touch. But when you ask and you register with the maximum force, this implant will touch. And this is very important, because if you don't do that, when this patient will work, this implant will receive overload. And the point is not the implant. The major risk is when I have implants when tooth, natural tooth. Why? Because this natural tooth will receive more force. And normally, I will have problems with this tooth in the future. I see a lot of that in the clinic. Normally, the patient, the adjustment not considered. And when I register with scanners to the lab, I align this information with the lab. Why? Because normally, when the lab planned and designed the crown over implants, they adjust the contacts for this alluvium. And for me, I register this position with maximum force. And I ask, and I say, I tell to the lab that I have already compensate these gonfosis, and they can use that occlusion. No, they don't tell you that they do that, but they do, because for them, when they don't consider this adjustment, this gonfosis, what happens is that the crown it's very high, and the dentist claim all the time, yeah, it's high. Then they compensate, and then when the dentist install this crown, I have no problems, and it's perfect. It's perfect because they compensate this. But if you register in a maximum intercuspal position with maximum force and don't tell to the lab, we will have a crown with no contacts, even in maximum intercuspal position, maximum force, because they relieve these contacts. Make sense?
Thanks a lot. No, all clear.
All clear? Okay. More questions?
One more question. The sensor for OccluSense, it's only for one use?
It's one use because of contamination, of humid, but this is the recommendation of the company, okay? But what happens in the reality? We don't use just one use because of the price, because I can use the same sensor for 20 registrations. Normally, I use 2 or 3 or 5 at the same consult at the same time, and then I would have 15 more registrations to make with that sensor. Then we clean it, and we keep with the name of the patient, the data that we opened, and I use. For example, when I open a sensor for oral rehabilitation, normally I use 2 or 3 sensor over the treatment, but I don't use one for each time. I use normally until its end, and then I open a new one.
Thanks.
More questions? No? So I have here, we have my contacts. If you have some doubts, please, you can send me direct messages that I'm here to help you. Okay.